Last week, we learned about how fluids and electrolytes and those imbalances can interfere with homeostasis. And so this week, we continue with the urinary system, which plays a vital role, particularly the kidneys, as they regulate fluid volume, blood pressure, waste, and then pH. So we're going to renew some A&P and then talk about some of the disorders and diseases found within the system that alter the stable internal environment that the body likes to function at. So the urinary system we know is made up of the kidneys, ureters, bladder, and urethra. Again, the main job of this system is to regulate fluid volume, blood pressure, excrete waste and medications, vitamin D conversion, pH balance, and then hormone synthesis. It forms urine, which is dependent on renal blood flow or perfusion, tubular reabsorption, basically reabsorbing substances back into the blood, and finally, its secretion function, or secreting substances from the blood into waste. Blood flows into the glomerulus, where filtrate is created through the tubules, where substances are either reabsorbed or secreted to be excreted. Interestingly, nearly 25% of cardiac output is directly related to kidney perfusion. And so when you think of clients with heart failure, hypovolemia or hypovolemia, those that don't have enough volume, if they're not perfusing, it makes sense that they become oliguric or anuric, as they won't make waste without perfusion of those kidneys. There are several examples of the kidneys having built-in compensatory responses, just like fluid and electrolytes. So these kick in when something's not right with a client, right? Either the disease process or it's more of an acute issue like blood volume loss or too much fluid. So if blood pressure is decreased, the renin, angiotensin, aldosterone system will attempt to compensate. It's going to cause vasoconstriction and a decrease in renal blood flow. Natriuretic peptides respond to increase in blood volume, so think heart failure, increasing urine formation. Urodilantin is produced and it inhibits water and sodium reabsorption, causing vasodilation and then diuresis. The kidneys itself have intrinsic mechanisms built in, like the juxtaglomerular apparatus that responds to pressure changes in the tubules. So when somebody's GFR, their glomerular filtration rate decreases, the afferent arteriole dilates, and that's where blood enters. And renin is released, causing the efferent arteriole, where the blood exits, to constrict, and that ultimately increases GFR. If a client has renal artery stenosis, where the blood is having a hard time entering the kidney, then vessels can dilate or constrict in response to sodium, water, and volume changes as needed. So let's talk about a couple of disorders. There are several diagnostic procedures that can be done to diagnose urinary disorders. Generally speaking, a physical exam is always warranted, along with a full health history. And so let's start with incontinence. Risk factors for incontinence, or the leakage of urine, is sex assigned at birth. So for stress incontinence, the risk factor is being born female. And for overflow incontinence, the risk factor is being born male at birth. Advancing age, being overweight, and smoking all play a part in becoming incontinent of urine. So clients with stress incontinence, typically women, are going to present with leakage of urine while sneezing or coughing. So anything that's stressing the bladder. Think of a pregnant female where the growing belly presses on the bladder. Those with overflow incontinence are going to present typically with UTIs because they're retaining some urine. They have increased frequency, nocturia, dribbling of urine, and then having trouble starting their stream. A lot of our older adult males with prostate issues have overflow incontinence. For our clients with incontinence, providers may order bladder stress testing, post-void residual measurements, meaning they'll measure how much urine is left in the bladder after the client urinates, a cystoscopy, where they insert a camera into the bladder and look around, maybe an ultrasound, and then for our males, a prostate-specific antigen that will show basically health of the prostate. The second one is UTIs, and while quite common, UTIs are more common in females than males, so sex assigned at birth does increase the risk. Most UTIs we know are from E. coli, and so women are more prone due to the shorter length of the urethra and then the proximity of that to the anus. Men with benign prostatic hyperplasia, BPH, are at risk because they retain urine. So again, that's a risk factor for males. Congenital structural abnormalities that block outflow or even renal calculi are risk factors, along with improper hygiene and then urinary catheterization, as we know. Signs of UTI include urgency, having to go more frequently but not urinating a lot, pain on urination, cloudy, foul-smelling urine, and even possibly hematuria. So most often, urinalysis and culture is performed. We may see white blood cells and maybe even some red blood cells in the cloudy urine collected. The number one risk factor for bladder cancer is cigarette smoking. Typically, clients that have bladder cancer will have painless hematuria. They'll also show signs of UTI, so frequency, urgency, and dysuria. And then with advanced disease, it may progress to flank and abdominal pain. Another condition are nephrolithiases, or commonly known as renal calculi or kidney stones. And this is the most common cause of urinary obstruction. So it prevents urine from exiting. Really, they're stuck in the ureters or within the kidney itself. So they're hard masses of crystals composed of minerals that typically the kidney would excrete, but these ones have become too large and then obstruct the outflow. Clients are going to complain of colicky flank pain, like severe cramping. Hematuria is frank or gross, meaning it's literally seen or it's seen on a urinalysis. There's pain with urination, and then nausea and vomiting are really, really common. Providers were typically diagnosed with a urinalysis because they see RBCs, and then a CT scan or an ultrasound. Finally, there are a couple more common disease processes that affect renal function, and those are acute kidney injury, which is reversible, and then chronic kidney disease, which is not, and it is likely progressive. So these two conditions impair renal function itself. Acute kidney injury is sudden, right? It could be due to pre-renal concerns like hypovolemia. The kidneys just aren't getting perfused, so they're not going to make urine. It could be intrarenal glomerular disorders or vessel disease, or post-renal things like ureter or bladder obstructions. There are phases to acute kidney injuries, and so initially there are no signs and symptoms. Once it gets bad enough, then there's an oliguric phase, which is decreased urine output, and that leads to electrolyte imbalances, typically fluid retention, and then even metabolic acidosis, so high pH and low bicarb. After renal function returns, there's a diuretic phase where there's increased output and then possibly even more electrolyte issues because of the increase in the urine. And then hemodynamic issues because so much fluid is lost. So dehydration is a complication. And finally, in the recovery stage, everything returns to baseline. That could take 3 to 12 months, but typically it goes back to normal for that client. Providers are going to look at a CBC, particularly at the creatinine and the BUN, the amount of output, and then a UA for sodium and likely osmolality, or how many solutes are in there. Chronic kidney disease, again, is gradual and it's irreversible. Most often it is caused by diabetes and hypertension, and those cause literal destruction of the glomerulus and the nephrons. So these clients have reduced GFR and are watched over time. Once half of the nephrons are destroyed, clients become symptomatic, and the complications are many. I mean, all the body systems are going to show signs of chronic kidney disease. Nausea and vomiting, loss of appetite, so GI, urinating more or less, right? It's eventually going to be a lot less, even to anuria. Muscle cramps, dry and itchy skin, decreased mental sharpness, so neurological issues, high blood pressure from the fluid retention, fatigue, weakness, sleep problems, swelling, edema, right, with the heart, and then even chest pain. So diagnosis here is made on GFR trends, and when needed, dialysis or transplant become warranted. So that's just a quick week recap and review of Chapter 7, which is urinary function. I posted some videos this week on the renal system overview and then chronic kidney disease and how that interacts with the cardiac and endocrine system. Assignments this week, technically nothing is due. One thing you should start to consider is what do you want to do for your teaching plan? This is assignment that you have in this class towards the end. Some questions to ask. What disease process do you want to know more about and teach a client? Or what disease process do you educate clients and their families on about already and would like to sharpen up a teaching plan? Have a wonderful week.